Well, good morning, everybody. It's Kevin Rudd here. I'm president of the Asia Society Policy Institute in New York, although today I'm speaking to you from southeast Queensland in Australia. I've returned to Australia several weeks ago to be with my family during the current crisis. We at the Asia Society Policy Institute have been running a series for the last several weeks now entitled The Coronavirus, Asia and the World. And that's because this pandemic affects all our countries. It began here in Asia. It began, of course, in China. It began in Wuhan. But as we can see from our daily media coverage, its reach in public health policy terms and in economic terms, and regrettably in political and geopolitical terms, is now extending right across the world. In the course of the last couple of weeks, we've already run series on the impact of the coronavirus on China itself, its economy, its politics, and its external relations. We followed last week with two in this series, one by our Vice President, Wendy Cutler, in Washington. Wendy spoke about the impact of the coronavirus on global trade and on the US-China trade deal in particular. And our Vice President of New York, Danny Russell, former Assistant Secretary of State for East Asia in the previous administration, Danny spoke about the impact of the coronavirus on China's Belt and Road Initiative. So we continue this series today. And today we're going to talk about lessons that could be learned from a country within our region which has been wrestling this coronavirus crisis to the ground in the best way they possibly can. And of course, here I'm referring to the Republic of Singapore, the city-state. And many of us have watched as the virus spread initially from Wuhan to the rest of China, but then as it came just prior to Chinese New Year, its extension particularly into the Chinese-speaking communities in Singapore and Hong Kong, to some extent in Taiwan, and of course not far behind, into South Korea and Japan. What has been remarkable for those of us who observed the management of these crises is the relative success with which many of these Northeast Asian countries, plus Singapore, have so far handled the crisis. As of today in Singapore, we have some 926 infections, and so far only 3 deaths. This is not all due to luck. This is due to a combination of public policy measures adopted by our good friends in Singapore. That's why I'm delighted today to be joined by Professor Teo, Professor Yik-Ying Teo from the National University of Singapore. Professor Teo heads the Swee Hock School of Public Health, and he has been integrally involved in Singapore's public policy response to the crisis. Professor Teo studied first at Imperial College, then at Oxford University. He was the founding director of the Centre for Health Sciences and the director of the Centre for Infectious Disease Epidemiology and Research before going to the National University of Singapore. So I can think of no better person to join us today. What I'd say to all of the people who are tuning into this webcast, whether you're coming through Facebook Live or through YouTube, or through other connections, if you have questions you wish to pose to Professor Teo, make sure you send those in so that they can be referred to me by my staff back in the United States through my own cell phone here. And at the end of our initial presentation here from Professor Teo, and after I've asked him some questions, I'll turn to some of the questions that you've asked as well. So how we're going to conduct this is, it now being about 4 or 5 minutes after the hour, I'm going to ask Professor Teo to speak to us for the next 5 to 10 minutes around these themes. What measures has Singapore taken? Which does Professor Teo judge to have been the most successful so far in containing the virus? Thirdly, what are those areas that he's still worried about as a professional epidemiologist? And finally, what are those areas where we could, all of us, do more, given that we are all trying to learn on the job through this horrific crisis affecting us all. So having given that introduction, let me turn now to Professor Teo for his initial set of remarks for the next 5 or 10 minutes. Over to you, Professor Teo.
Thank you very much, Prime Minister. So I think Singapore, we saw the first case in Singapore actually on the 23rd of January. But actually prior to that, Singapore recognized that the impact of this problem actually goes beyond the health sector and very quickly put in place a multi-ministry task force to oversee the overall national response. The task force included the ministers from health, from trade, communications, education, national development, and other relevant ministries as well. This is a very important signaling because it signaled that the crisis from the very beginning, it's beyond a health crisis, but rather a national crisis. And with that in mind, this is where the country is able to put in place the measures that actually cut across different industry, including education, trade, and communications beyond health. And some of the key strategies that I will talk about, I will highlight just 3 key strategies that I find has been most relevant to the Singapore's response in managing this outbreak at the moment. The first key strategy really is around how we are trying to find the people that are infected, perform very rigorous contact tracing to find out who are the contacts that have been exposed, isolate these people, quarantine these people very early on in the whole infection chain. This has been extremely difficult to execute because the sheer amount of work in terms of contact tracing, in investigating all the possible contacts, that has been very difficult, but it has been executed well, and that, in my opinion, has been one of the biggest reasons why Singapore has been able to manage this well. The second reason has to be the communication that we put in place, again, very early on in terms of where the public is going to get information from. And this communication is centrally coordinated at the government level. There is actually a WhatsApp platform that citizens can sign up to. And from that WhatsApp platform, they get 3 kinds of information. The first, it's really what is the current state of the situation in Singapore. Transparent, no packaging, but the raw facts in terms of the number of people affected, where the clusters are, and how this is being spread. Current situation. The second form of communication is really around what are the measures that individuals like you and me can take to help the country minimize further onward transmission. The third form of communication is really around regulations that are put in place, the new rules, because as the epidemic evolves in the country, new regulations are constantly being introduced in terms of which countries now have travel advisories, which country there is a ban in traveling, receiving travelers from. Regulations are communicated very clearly to the public, and the communications has been one of also a very key national response to the outbreak that we see in Singapore. The third key strategy has to be relying on the evidence-based approach in policy setting and to have a very nimble approach in deciding at this particular stage in the epidemic outbreak what is necessary policies to put in place. So focusing on what to do now as a country and also relying on evidence to focus on what is coming next. So there are aspects that we rely on modelers that are in the scientific community, on the virologists, on the infectious disease experts, even on synthesizing data and evidence that is happening, that is being produced around the world. So back when the world was trying to make sense of the outbreak in early parts of January, in early parts of February, there was a lot of data that was emerging from the affected countries, including China, Singapore, Korea, and now in Europe and America. Singapore actually already had put in place a machinery to really gist through this information, process it, and repackage it in a manner that is operationally useful to the policymakers. So that was the second approach that has been very important. The third, I talk about the communication as a key strategy. That communication actually underpins also a central message that we share in Singapore, which is the personal responsibility, that people lies at the heart of the response to this outbreak. And it is by individuals taking that personal responsibility to maintain personal hygiene, to stay at home when necessary, when ill, and not to go out to the public to transmit on further infection. Those are the key strategies that I believe have worked. So I will repeat 3 key strategies. Firstly, really contact tracing, isolating, and rigorous testing. The second is really around our communications to the public, telling people what is the personal responsibility. And the third is really relying on evidence to decide what are the policies to put in place at which stage of the outbreak. Right now, as Prime Minister Rudd has mentioned, Singapore, we are at a situation where we have 926 cases in the country now. If we look back at what has happened in the past week, the majority of the increase has actually come from people returning back to Singapore from countries in Europe, in America. And with those information, this is where we change our policy accordingly to isolate and quarantine people that are returning up to 14 days. They are put away from their family appropriately so they do not have the chance of spreading this even to their family and to other parts of other people in Singapore. So those are very key responses that Singapore has put in place. Now, if we look at what could be coming next to Singapore, and those are some of the measures that countries have to consider what to go beyond the existing measures, there will be further transmission within the country. And that is why the country now has put in place very strict physical distancing measures at the workplace, at public spaces, including closing down of cinemas, pubs, clubs, places where people congregate and in a large human density. Those are places that we close down now. Even in malls, we put in place strict laws to encourage people or to mandate physical distancing between people. That is the way that we see necessary to get people to be responsible, to practice the necessary personal hygiene and physical distancing, that we can try and break onward transmission of community cases in the country. So with that, that's a very brief introduction, and I'll pass it back to Prime Minister Rudd for further discussion. Over to you, sir.
Well, thank you very much, Professor Teo. That's been a very useful summary introduction. So I've got it in summary form, 3 sets of measures. One, through proper testing, proper contact tracing, and then subsequent isolation, reducing, as it were, the scope and potentiality of individual carriers. Number 2, the various ingredients of your public information strategy, which sounds to me to be comprehensive, not just consolidated messages from the government about what individual citizens can and must do themselves to assist in bringing the virus under control, but what regulations have also been put in place on larger decisions to be taken. And you mentioned, of course, travel movements has been key to that. And I think the third one you mentioned, if I've got it right, is in fact a rolling model of testing the efficacy of your current policies. That is, you have a set of policies in place, and what you're seeking to do is to deploy big data to the extent that you can from foreign jurisdictions and from your own to assess impact of measures taken so far, and therefore to identify gaps in terms of what still needs to be done by way of problems which continue to exist. That's my best summary, I think, of what you have just said. And so let me begin with one question which is often put to us in the international community, particularly by our friends in the Northern Hemisphere, with a sense of hope, and for those of us in the Southern Hemisphere with a sense of intrepidation, which is what is actually your judgment, and where does the professional literature stand on this question of the impact of climate and temperature on the spread of the virus over time? Your thoughts on that, I think, would be welcome to our listening and viewing audience around the world.
So on this issue, I'm actually a little bit more pessimistic compared to what the people have. There's the popular belief that the outbreak will go away, in a manner of speaking, that when the temperature in the northern hemisphere actually increase. We saw that with SARS, that actually SARS disappeared come warmer climate. And given what we are seeing right now in terms of a universal transmission across 199 countries in the world, looking at the spread of the disease, I'm less optimistic that the situation will improve with rising temperature. Because even in a country like Singapore, it's tropical year out. And with that, we are also seeing similar other countries, tropical countries, suffering from widespread community transmission. So I'm actually less optimistic that the situation will improve. There are studies that have shown that the virus actually don't perform that well in warmer climate because of the biomolecular structure of the virus. That it's an indication perhaps it doesn't spread as well, but it is important to distinguish between whether warmer climate will significantly improve the situation to reduce the epidemic outbreak in individual countries versus a situation where it spreads less well, so there may be a milder impact, a small impact in terms of the transmissibility, but nonetheless countries will still suffer from a significant outbreak. I actually believe that based on what we're seeing in the Southeast Asia countries, temperature and climate is not going to have that big a modulating role to significantly improve the situation. Over to you, sir.
Thank you very much for that. Those are important reflections on the question of climate, given that I think all of us who have followed the literature on this see some divisions in the international scientific and public health policy literature on this subject. I think if I've got the summary correct from what you've just said, if there is a climatic effect, it may not be huge. That is, there may be some reduction in transmissibility in warmer climates, I think, with greater humidity, but not the elimination of transmissibility, which I think was very much the case with SARS, if I'm correct, in my historical report.
Yes.
Thank you. Another question in terms of personal behaviour, which has been raised by many, and I'll actually go now to a question which has been raised by someone who is viewing our broadcast. Matt Nelson on Facebook says, generally the public use of face masks are regarded as not materially useful unless the person themselves are symptomatic, where it reduces their transmission to others. Does Professor Teo think that the widespread use of face masks by members of the public in Southeast Asian countries, including in Singapore, contribute materially to the lower transmission rates? Your thoughts on that, Professor Teo?
Thank you. So on the issue of face mask, it is very clear that face mask does have a certain degree of contribution in reducing the transmissibility of the virus, particularly if I'm an infected person and if I have my face mask on. Clearly, the aerosolization of the virus from my speech and from my activities will be significantly reduced. Equally, if there are people who are infected and who happens to be sneezing or coughing around me, having a face mask does confer a degree of protection. But at the same time, this is where we have to balance the overall effectiveness of the face mask with very operational issues such as, do we have sufficient face masks for general public to be using in a somewhat indiscriminate manner? So right now, the world is facing a chronic shortage of face masks, and this is a very big problem, even for health, especially for healthcare workers. I cannot emphasize this enough. Healthcare workers require the face mask to execute their duties in a safe and protected environment. The moment that we are unable to protect our healthcare workers, the situation will escalate quite badly. Now, with that in mind, if we now come back to a situation where if there are infinite supply of face masks, that is great. Everyone will be greatly encouraged to use face masks to protect themselves and also to minimize the spread. But in a situation which is what we're facing, the world is facing right now, and that is where there are finite resources around personal protective equipment. This is really where we need to be very prudent in our use of face masks. And there have been people asking me, Singapore started off with the ideology that actually, if you are healthy and you are well, you will not require face masks. I still stand by that logic, depending on the country's situation. If the country is not facing widespread community transmission, there are just localized small clusters of infection, the general public actually do not need to wear face masks in their daily activities if they are not going to hot zones such as airports, such as hospitals, where the risk is much higher. I will just take 1 or 2 minutes to actually use this analogy. Motorcycle helmets. Motorcycle helmets, everyone riding a motorbike must wear a helmet because they are in a risky environment, they are participating in a risky activity. The helmet protects individuals who are riding motorbicycles. But do the general public need to wear a motorbicycle helmet when they're just walking along the street, when they're at home, or when they're working in the workplace? The answer is no. Why not? Because helmets do still confer that protection, but because the environment, the activities that you're engaged in is of a much significantly reduced risk, that is why there isn't actually a need to wear a helmet if you're not riding a bike on the roads. So with that analogy, I hope it paints a picture of at which stage should individuals, even the public, be thinking about wearing masks, and at which stage is actually wearing a mask not going to be that necessary. So in the early phase when there is not significant transmission, and if everyone in the public is wearing masks, people run through 3 or 4 masks at the minimum a day. A population like Singapore, almost 6 million, that means we need, excluding perhaps the young and the very old, perhaps we will need in the order of 10 million masks every single day. If the public is burning through masks at this rate, there will not be a sufficient supply to allow our healthcare workers to have the necessary protection in order to execute their work properly. If I could also just very quickly touch on the use of other forms of masks that are not surgical masks, and I think there is now growing evidence that actually having some form of covering, whether it is a cloth mask, a homemade mask, can help to reduce that onward transmission of aerosolization of virus. So for individuals that have that fear, having a cloth mask is better than not having a mask. I think that there is evidence to suggest that is true, but I must still emphasize, mask is no replacement for personal hygiene behavior. Hand washing, hygiene, because touching surfaces, the form might spread, it's still deemed to be a very significant source of infecting others. So a much better approach is still to maintain personal hygiene, covering your mouth when you're coughing or when you're sneezing, and washing your hands often with soap and water. Simple public health hygiene messages like this is going to do a lot more good in a very cost-effective, cost-efficient manner than people starting to use surgical masks indiscriminately. Over to you, sir.
Good, thank you very much, Professor. So if you see someone wearing a motorcycle helmet and a mask, you know we've got a problem on our hands. So let me turn to a question which is emerging in some of the public literature, which is on the extent to which those who are non-symptomatic but who have been infected with the virus represent a continuing ongoing risk in terms of transmission to others who will of themselves not necessarily end up as being non-symptomatic. How big a problem is this question of non-symptomatic carriers? And is there anything in addition that can be done to deal with this problem beyond, I presume, universal testing and isolation? Your thoughts on that, Professor?
So on this issue, this is really where the understanding of the disease dynamics have changed over the past few weeks. In fact, the world has only seen this for about 10, 11 weeks. But in 10, 11 weeks, our understanding of the disease dynamics have changed. In the very beginning, there was the strong belief that this asymptomatic transmission is highly unlikely. But increasingly, with additional testing, like what we're seeing in Italy, like what we did with the cruise ship, it is now, and particularly Iceland. Iceland has done very well in shedding further light on this situation of asymptomatic transmission. We now see evidence that there can be asymptomatic transmission. Now, this is worrying because it means that individuals who themselves are not ill at that particular moment, no clear symptoms, no high fever, they could be shedding virus. And that does mean that the risk of spreading becomes greater. Now, in a situation where there is now worrying cause of more people within the country being infected, this is where physical distancing measures become absolutely important. The recommendation or the mandatory requirement of people to stay apart, to stay at home, that is a way to try and contain any onward transmission. But asymptomatic transmission, right now, there is evidence to suggest that is happening. It is a worrying situation. Individuals can minimize the risk to themselves and to others by really maintaining the necessary physical distancing at the workplace if they are going to work, or at home, minimizing the degree of interactions with particularly elders in the family. Over to you.
Thank you for those remarks. Again, on the question of non-symptomatic transmission, apart from the social distancing and personal isolation measures you pointed to, does the problem of non-symptomatic transmission point us also in the direction of more comprehensive, indeed universal testing of our entire populations, if in fact those resources were available to individual countries to do so? Your thoughts on that, Professor?
Thank you. Mr. Ru, your last comment on if the resources are available is actually extremely important to put that in the right context, because indeed there are two types of tests that countries can perform right now. One is the antigen PCR test to find out whether an individual is currently infected. The second is actually an antibody serology test to find out whether an individual has been infected before, has been exposed, perhaps has recovered, and so they have signs of antibodies in their circulating in their body that we believe may protect them from subsequent infection. Now, widespread population level testing of either would be tremendously useful, but they are useful in different sense. The biggest issue right now against widespread population testing is really around the availability of test kits and reagents for the PCR antigen test. Countries right now are running out of supplies to perform the necessary PCR test to find out are individuals infected or not. So being in a state that you can run as many tests as possible is definitely helpful, because it allows you to identify who are the people who are currently infected. You can find out who they have been in contact with, and you isolate the rest of this context to minimize further transmission. So that is really the reason why we talk about maximizing your ability to test as rigorously as possible. But because resources are running out, we have to be very prudent in how we apply this test to the general public, but rather to prioritize the use of this test to those that are under suspicion of being infected or also to prioritize them for use on healthcare workers who are at much higher risk of being infected. The second type of the second type of test is actually on the serology test, and we can talk about that later on. But again, serology tests, they have a different purpose to apply it either in a small scale setting to learn about what is the likely proportion of the people in the country that has already been exposed. And those information is useful to guide governments in terms of when to relax some of the national measures that have been put in place, or perhaps to step up some of the national measures. But at the moment, I will stop there. Over back to you.
Thank you. That's very useful to point out not just the constraints in terms of global and national supply of testing kits, but the fact that we're talking about two different types of tests for, as it were, different purposes. And that with or without universal testing, the ultimate importance of social distancing and where possible individual isolation still provides the most effective guarantee. One final question, Professor, before I take a series of questions now banking up from those who are tuning into this webcast, is Singapore's policy on school closures. Many countries and jurisdictions around the world have closed schools as part of a general social lockdown. The lockdown, of course, excluding emergency services, obviously health services, but also food, pharmaceutical supplies, and what would broadly be put within the category of essential services. And there's been a vexed debate about school closures. One of the considerations, of course, has been that the children of many healthcare workers, if they are no longer at school and are at home, who looks after them? And given they can't be handed off to grandparents because grandparents are vulnerable in terms of age, then we have a problem because of a diminution then in the overall size and effectiveness of our health workforces. But I'm interested to understand the public policy basis for Singapore's decision on schools and keeping them open. What particular additional measures are you taking within schools in order to, as it were, monitor the circumstances there? And may this policy change in the future? Your thoughts on that, Professor?
So, thank you. Firstly, I could talk about the rationale why Singapore, we do not advocate closing schools at the based on the current situation. And then I will talk, secondly, about the measures that are taken in schools to minimize risk as well. So on the reason why we currently do not close schools, and this is where we really have to come back to the science again, which is one of the things that I highlighted as one of the key responses in Singapore, that we rely on scientific evidence to determine what are the policy that we should put in place. At the moment, the understanding and the literature really suggests that children are at a much lower risk of being infected, or even if they're infected, they have much milder symptoms. So there's no evidence that they are the vectors. They are the ones that are spreading the disease at the moment. So really from the science, closing school, it's not going to help mitigate the risk that much given the current situation in Singapore. So first is on the science. The second is really, if we now look at the cultural context of what closing schools will mean in Singapore, it actually says in Singapore, a lot of the children, if they're not in schools, they will be looked after by caregivers, such as grandparents, like Mr. Root, you mentioned correctly, and getting children who are interacting with grandparents within a close proximity, in a way, one can debate arguably whether that is a good decision, regardless of whether children are the vectors or not. The third, it's really around the impact on the workforce, because when children stay at home, clearly adults will have to stay at home if they are not farmed up to the grandparents. At least one of the adults will have to stay at home. Not all, I have to emphasize, not all children have the luxury of being looked after by grandparents. If not the case, it means that people currently in the workforce will need to remain at home to help look after the children. this will impact the workforce, and more importantly, it will impact the healthcare workforce and that of the other essential services as well. So, and those are the key three reasons, but I think it's important to also put it in the context. I have to emphasize that Singapore is not stubbornly refusing to close school, but we are adopting an approach that is guided by what is the current situation and what is the likely situation moving forward. The country will close schools. To the best of my knowledge, the country will close schools if and when the situation requires. But prior to that, we will not necessarily perhaps use the word overreact by closing schools prematurely before they are necessary. Now, if we don't close schools, what measures do we put in place in the schools to make sure that children, even though they are mingling in the classrooms, they are not, the risk is managed and minimized as much as possible. So this is where we have very strict temperature taking at the beginning of the day and during midday as well, twice a day. Children are required to take their temperature to make sure that if there is a child with evidence of high temperature, they are immediately sent home, isolated, and sent home appropriately for the necessary care. So temperature taking is one. And secondly, I talk about physical distancing measures, and these are equally applied in schools right now. So there is a significant reduction of activities that allow them to mingle. So cross classroom interactions have now been reduced. There are no activities, the extra activities that happen after the end of the school, those have been cancelled as well. So within a school context, we have really put in place the necessary measures to minimize minimize interactions between individuals and really maximize physical distancing. This happens also at the canteens where the students are getting their food, as well as in the halls and classrooms where the tables are partitioned as far apart as the classroom space allow. So back to you.
Thank you very much, Professor. A question from Josh Price from Facebook, who asks, how is Singapore monitoring social distancing in food centres and wet markets? Because we all know in Australia that all you Singaporeans are naturally law-abiding, unlike most Australians. But our interest is how you're actually going on the enforcement of this, and has it presented a problem for you? Over to you.
So the enforcement has actually been there are enforcement measures that are put in place. For example, the Ministry of Manpower actually conducts inspections of workspaces right now in the past week to ensure that companies, businesses are keeping to the rules, and they do not hesitate to issue what we call a stop work order, meaning that the building has to close until it can remedy its physical distancing measures and to reassure the Ministry of Manpower that it has now complied with the necessary regulation. And this goes beyond just businesses. It applies to student hostels, student dormitories, also to public spaces such as malls, where there is now a quota system that allows a fixed number of people to enter a shopping mall at any point in time to minimize human traffic within the malls. Now, you talk about the wet markets. Now, the wet markets has been one of the areas that it's a lot harder to police and to enforce just because of the nature of the interactions. And this is really where some of if you combine some of the additional messages around trying to minimize going to the supermarkets or to the wet markets unless absolutely necessary, consolidate your purchases in one or two purchases rather than going every day, is trying to help to minimize the human traffic that are showing up at these places. Another hotspot that I can talk about that is always difficult to minimize human traffic are lifts and also your public transportation like buses, like the trains as well. those are spaces that it's very difficult to enforce that minimal distancing, whether it is 1 meter or 2 meters. And this is where you have to put in place other measures such as staggered working hours, where people come in later or earlier and then go off later and earlier to try and minimize human traffic in all these places. I think the point is the public have to understand what is the principle behind some of these measures and to find ways to cope with how to keep to these measures. The principle here is really to maximize physical distancing between individuals as best as you can, and to make certain changes in your own behavior and your own routines that will allow that to happen. Over back to you.
Thank you very much. That's very helpful. I've got a couple of questions here from a William Eichenberger, and I'll give you them both questions at once, but I think they're excellent questions. Do we have a better idea of the real CFR now? That's case fatality rates. And there you might reflect on not just your own data. We've in fact had only 3 deaths, but global data. That's one question from Mr. Eichenberger. And the second one is, are the authorities in Singapore assuming that those who recover from COVID-19 now have immunity? I put those 2 questions to you, Professor.
Right, thank you. Thank you very much for the question, Mr. Eichenberger. And on the issue of the real CFR, I have 2 answers. One is an academic answer, and then one is a practical answer. The academic answer actually is around the CFR. Based on current understanding, it seems to be hovering between 1 to 2%, based on data that's coming out from China, Italy, and Spain. The CFR appears to be hovering around 1 to 2%. If you factor in the time lag between when people get infected, the time that they have to spend in the hospitals before finally mortality hits, it seems like it is between 1 to 2%. That's the academic answer. The operational practical answer that I would say is actually the CFR. It masks the situation badly, and it also distracts from the real operational concerns. Why do I say that? If I have infinite resources at the healthcare setting, meaning I have infinite number of intensive care units, infinite number of ventilators, the CFR becomes easy to estimate what is the true value, and it is a value that policymakers can use to gauge their policies. The problem is right now, we know very well that actually the fatality rates really depends on the ability for health systems to cope. And what this means is if the number of infected people coming into a hospital way surpass the number of people that is being discharged, that difference means every day my hospital is getting more and more crowded, and at some point I will hit the maximum capacity. Now, the maximum capacity here, what is very important is actually the intensive care units as well as critical resources such as ventilators. About 5% of the people that are looked after in hospital, we know they progress to a degree of severity that they need to be put on ventilators to help them breathe. And this is where intubation becomes important to the survival of an individual. So if the healthcare system is stretched to the point that they cannot cope, fatality rates increases tremendously. So that is why if you look at the crude fatality rates from a country like Italy, it is actually around 10% and above. But that is a sign that your healthcare system is severely stretched. And that is why I like to emphasize that looking at the case fatality rates is an academic problem. It is very interesting to people who are performing the modeling. But from a practical perspective, as a policymaker, my worry is always around how many ICU beds do I have? How many ventilators do I have that can be dedicated solely to the coronavirus response? And at which stage in time will they be completely used up? And that's when, if someone needs a ventilator but is unable to get one, that's where the chances of that person dying increases tremendously. Beyond that 1 to 2%, perhaps even beyond 10%, if the resources are severely stretched. And that is why I think the real case fatality rate at the moment, in a way, it is an academic issue. Statistics suggest it's about 1 to 2%, but operationally, we really have to look at the fatality rates with respect to the availability of healthcare resources. The second question from Mr. Eichenberger is around the conferment of immunity for people who have been infected before and recovered. Based on the data that is coming out from China and also from what we are seeing in Singapore, it seems to suggest that people who are infected and have recovered have not been really reinfected again. So it does suggest that there is a degree of immunity that is conferred to people that has already been exposed. Now, based on our understanding of other coronaviruses, this degree of immunity, it's likely to be there, but whether it lasts for a lifetime, for a long time, or for just a short time, this is the point that we don't know at the moment. For another coronavirus, which is SARS, we have seen that people who were infected back in 2003, they appear to be still possessing the antibodies at this point in time in 2019, 2020. So after a period of 15, 18 years, they are still possessing the antibodies. So is this the same for the coronavirus that we are dealing with right now? I don't think we have sufficient evidence to suggest so, but at least based on empirical evidence, people who have been infected in the past, they have not been reinfected, but we can only hope this antibody will persist for a long time, so the concept of herd immunity can come in at some point. Over to you, sir.
Thank you again for those remarks. I think we'll start to draw our conversation to a close. You've been very generous to us with your time today. And as I said to you yesterday when we had an earlier conversation, you have a real and important job to do in Singapore. But let me conclude with this question, which is fairly open-ended, which is what are the things that worry you most about the month ahead in Singapore? What are the things that worry you most about the month ahead elsewhere in the world as far as the coronavirus is concerned? And what measures that we're not currently embracing may we then need to consider embracing?
Right. So in terms of the situation in Singapore that worries me most, I think that would be when we start to progress on to widespread community transmission. Very fortunately, we see limited community transmission. It is not widespread at the moment. So I have faith that the situation is still being contained well, given the very active and robust contact tracing and isolation policies that we have. It will worry me a lot if over the next few days, it doesn't have to be a month, over the next few days, there are very clear evidence that there are increasing number of often unlinked cases emerging in the community. There are more sporadic clusters that are being reported. That will be a sign that the infection has taken root in the Singapore community and is spreading much more widespread. And that will be a worrying sign for me. Across the world, actually based on some of the very recent data coming up from Italy, from Spain, and even from the United Kingdom just yesterday, there is evidence to suggest that the lockdown measures, the very strict people movement measures that have been put in place in these countries have begun to change the way the disease is transmitting in the countries. The curve, the API curve as we call it, seems to be bending and the number of new infections are reducing. I have to highlight the number of deaths appear to be at an all-time high, but because I mentioned earlier on, deaths takes a while to catch up, and these are people that have been admitted in the past 14 days. But the number of new infections that are being reported with very active testing has been falling. And those are very encouraging signs that the countries are being able to, the measures that are put in place are succeeding in limiting and in controlling the spread. But what will worry me a lot is if there are signs of widespread transmission in countries in Africa, in Latin America, where these are typically countries with weaker health systems and weaker governance structure to manage this. And that will be a very worrying sign that the epicenter may be shifting to countries with fragile states and with weaker systems in place to manage this. These are also the countries with poorer ability to implement some of the measures that we've talked about in terms of even contact tracing, in terms of rigorous testing. Those are measures that are not easily available and option available to many of these countries. That is something that worries me tremendously, that the epicenters shift down south to continents in Africa and in Latin America. Now, in terms of what other measures that countries can put in place, I think this is where we have to start to think about where countries are at given the current situation they are with the disease. If they are still at the very fortunate stage that despite very active, rigorous testing, they see very sporadic clusters on very few cases, make sure they try their very best, contact trace, contain, isolate, and quarantine the people that are suspected of being infected. That is the way that you can keep a measure. Understand where the cases are coming from. If it is coming from overseas with importation, this is where countries have to think about whether they should partially close their borders to some of the hot zones or even have a complete closure. If they choose not to close the borders, they must have in place the necessary isolation and quarantine policies such that people returning from overseas are kept away from the general public for 14 days to make sure that they are clear from being infected before they are allowed back in the community. But for countries that are in the worst end of the spectrum, widespread community transmission, they must put in place the necessary measures to allow their healthcare system to recover. And this means perhaps having a national lockdown will become necessary. School closures that I talk about will become necessary just to reduce people movement in public. Public transportation networks could be closed. Those measures implemented in China in the early days, in Italy, in Spain, in the UK, those are the measures that we are seeing have worked, and those will likely be the measures that will need to be recommended in situations where there's widespread community transmission. Over back to you.
Let me conclude by just picking up one thread of what you said before. If you are looking to the month ahead and looking at emerging data lines, what regions of the world are you most concerned about? You just touched on Africa, you just touched briefly on Latin America, you did not mention South Asia or your own wider region. If we're having this discussion in a month's time in terms of the movement of the epicenter, which went A from China, B into near East Asia, C to Europe, D to the United States, I suppose my question is, where is E? And I know that's an unfair question because it asks you to take out your crystal ball. About a month and a half ago, I said to general disinterest and disbelief around the world that China's January and February would become the rest of the world's March and April. Regrettably, I think that's proven to be accurate, but I'm thinking about what does the rest of the world now look like in May and June. So your final thoughts on that, Professor, then I'll let you get back to work.
So you asked a very good question of where is E? And I think to all the policymakers out there that are listening into this, the best way to think about E is that it is your own country. Put in place the measures as if that what is happening in other countries will be what you will be facing in the coming month ahead. Those will be the way to think about how a country should be responding at this point in time. thinking that it will not come to the country will be wishful thinking. I don't think that would ever happen. So from a country's perspective, they have to look at what happens if now we are starting to see clusters. What happens if we're now starting to see community transmission? It will always start off as sparse or low levels of community transmission before escalating up to a level that is widespread. There is always a trajectory. But the countries that have the time right now should ask themselves, if my country is the next epicenter, if my region is the next epicenter, what do I do right now to prepare my country for that? And this is where one should really start to think about strengthening the healthcare system in terms of identifying what are the surge capacity that can be provided, increasing supply of intensive care unit beds, and that may require some degree of maneuvering among shifting patients out or reducing the care for some of the people in current intensive care units, including also acquiring the necessary personal protective equipment as well as ventilators to prepare for it. So the best answer that I can give you, Mr. Root, is think about every other country now who are not at A, B, C, or D to be potential E. And that is the way that countries can plan for their response. Equally, for individuals, I have an advice which is, whenever you are unsure whether you are infected or not, consider yourself as being positively infected with COVID. That is the way that then you make the necessary decisions, the necessary responsible decisions. So if you are suffering from a mild fever, a cold, or flu-like symptoms, and you wonder, have I been infected? What should I be doing next? Always assume that you are infected and ask yourself, what do I do next to first minimize the risk to my family members, to the general public, and secondly, how do I seek care for myself such that I again minimize the risk to healthcare workers and so on. So two different statements to end off with. One is for countries and one is for individuals. Over to you.
Well, thanks very much, Professor Teo. You've been very generous with your time today. We're almost at the hour point now. And thank you for a visit around the world in terms of global public health policy, informed by your Singaporean experience, and for that last GP consultation you gave us all as well about what to do if any of us begin to feel the symptoms. Thank you also for being prepared to share the learnings you've achieved so far in Singapore. We at the Asia Society Policy Institute are in the business of shedding light, not heat, and in these charged times. And part of the light which needs to be spread around the world is what's working and what's not in terms of public health measures and, frankly, economic measures as well in dealing with the implications of this crisis. Next in this series from the Asia Society Policy Institute, this Thursday in in New York time, which will be on the 2nd of April. That's going to be Wednesday, I think, in Washington and New York. Certainly it's the 2nd of April, the impact of the coronavirus on Southeast Asia's economy, political systems and regional relationships. And then on the 7th of April, we're having one on the impact of the virus on Iran, given it's been a large epicenter itself for some time. So that's ahead in this series brought to you by the Asia Society Policy Institute. But if I can conclude today's talk by thanking you, Professor Teo, for all the good work that you've done both in Singapore and your preparedness to share your wisdom around the world. And from all of us in the international community, we continue to wish you well in Singapore. And for those of you in the medical profession, and those of you in the public health profession, as your expertise is now more valuable than it's ever been for all of us in the general community. So thank you, Professor Teo, on behalf of us all.
Thank you. Thank you very much, Mr. Root. Thank you.
Okay, that brings our broadcast to a close. Thank you very much, everybody.